The article I'm reviewing is entitled Serum Phosphate is an Early Predictor of Outcome in Severe Acetaminophen-Induced Hepatotoxicity. I'm going to talk just a brief few minutes about the background because I'd never heard of this before, which is not surprising. One of the biggest problems with acetaminophen-induced fulminant hepatic failure is the decision on who do you transplant. And we all know there's psychosocial issues that in our institution get most people off the transplant list, but you've also got a patient population who's potentially survivable, which is not good to put an orthotic liver in. They rapidly progress and they often have multi-system organ failure, making them kind of poor surgical candidates to start. Most, I don't know if most places, but probably the best studied transplant criteria is the King's College criteria. We all know this pretty well, pH less than 7.3, or a combination of an elevated INR, encephalopathy, or elevated creatinine. In a meta-analysis in 2003, the sensitivity of the King's College criteria was about 69% on mean, and specificity about 92% with the ranges from each of the studies there, which gives you a likelihood ratio of about 12.33. Or negative likelihood ratio of 0.29. Okay, so the background for this particular study is there was a couple case reports in the late 80s on serum phosphate levels in folks with acetaminophen-induced liver failure. And these two case reports showed that the patients they had who had liver toxicity had lower phosphate levels. And so that led, and I'll show you, I sort of adapted this graph from one of the case reports. And what you see is in patients who overdosed on acetaminophen but had levels that were below the nomogram line and did not require treatment, they had normal phosphate levels. And then if they had a toxic ingestion but did not get hepatotoxic, so they got treated but did not get liver failure, their phosphates were a little lower. If they developed hepatotoxicity with the standard definitions, but no encephalopathy, they were even lower. And lastly, if they developed hepatotoxicity and encephalopathy, they had the lowest serum phosphate levels of all. So this led the two investigators from the study in 2002 in hepatology to look at serum phosphate as a potential early predictor of outcome in severe acetaminophen-induced hepatotoxicity. This was really a prospective observational study. It was a 2-year period at a big tertiary liver center in Denmark. So all the patients that were sent to this center in this 2-year period that there was concern for acetaminophen-induced hepatotoxicity were enrolled in this study. All of these patients had NAC, IV NAC. They all had daily phosphates, serum phosphate levels drawn. They all had daily metabolic panels and daily INRs. And if you look at the demographics of this patient population, it's kind of what you would expect for a patient who's referred to a liver transplant center. Pretty big ingestions of acetaminophen with pretty long times to the first treatment with NAC. So about 23 hours was the time to NAC in most of these patients. The outcomes they were going to look at and correlate with serum phosphate levels were hepatotoxicity that they defined as severe, and their definition was an ALT greater than 1,000. Encephalopathy, and I wrote grade 2 or 3, but I apologize for that. It's basically grade 2 or above, so 2, 3, or 4. And then whether the patient required a liver transplant or died. And here's what they found. Looking at serum phosphate on day 2, on the left hand here, you'll see that in the patients who had no toxicity at all, they had normal serum phosphate levels. And those who developed, by their definition, hepatotoxicity, their phosphate levels are actually a little bit below those without any toxicity. Same with those with hepatotoxicity and hepatic encephalopathy. But of interest, and I would imagine surprising to them, is that they found that patients who died or required liver transplants actually had elevated serum phosphate. And these findings were the same either post-overdose day 2 or post-overdose day 3. And, oh good, it shows up. So if you look at this, you can sort of see in patients who developed hepatotoxicity, those who did not develop encephalopathy had low serum phosphate levels of 0.67. Those with hepatic encephalopathy had elevated levels at 1.78. But you can get the gist that it's a pretty wide range because the error bars are 1.3. So if they took that subset of the patient population with hepatic encephalopathy, and they looked at those who survived and those who didn't survive, what they found out is that those who survived actually had phosphate levels of 0.68, and that those who died actually had significantly elevated phosphate levels of 2.65. And the creatinine line I highlighted just to show that, as you might have already surmised, that those who had elevated phosphates also had elevated creatinines. So they did some ROC curves to maybe look at phosphate as a predictor of mortality. Based on the ROC curve, they came up with a level of 1.2 millimoles per liter in the serum as their predictor. So when they used this criteria, then anyone with, on day 2 or day 3, a serum phosphate greater than 1.2, what they found is that, if you go down the third row here, either phosphate criteria gave you a sensitivity of about 89%, specificity 100%, with, of course, wonderful positive predictive, negative predictive value, and accuracy. And they also applied the King's College criteria to the same patient population and showed, or at least report that they show that it was superior. So this is the author's conclusions, not mine. Their conclusion was that hyperphosphatemia after acetaminophen overdose was seen only in the non-survivors, that a serum phosphate level that is greater than 1.2 millimole per liter was actually a better predictor of, I wrote survival, but of death, I apologize, than the King's College criteria. Hypophosphatemia was actually associated with survival, not with death, and that hyperphosphatemia was also associated with renal failure. Okay. Now, outside of this, when you look at the article, if you PubMed it, you see lots of letters to it. And that's because there's been 3 studies that have sort of tried to refute or refuted these findings. I'm not sure that's English. In Hepatology 2003, Bernal et al. Showed that in their patient population, a similar patient population, that phosphate was no better than the King's College criteria. Go et al. In Hepatology, same issue, showed data that actually phosphate was worse than the King's College criteria. And then another study out of liver transplantation in 2004 showed another set of data that showed that phosphate was not a reliable indicator of survival. So I think for the LSA, you'd want to know a serum phosphate that's greater than 1.2 millimoles per liter on day 2 or 3 after acetaminophen overdose was associated with non-survival. That phosphate in this particular study was a better predictor than King's College criteria, that elevated phosphates were likely secondary to renal failure, and that actually hypophosphatemia seemed to be associated with liver toxicity that then went on to recover. I think for the real world, I think an elevated phosphate is probably no better than what we have right now.